Well, it's a real pleasure to be here. I'm very honored for the invitation and the opportunity to talk with you. I can talk about this topic for a very long time, but I'd appreciate if somebody gives me a hand signal when it's time to stop. These are my disclosures. So, who is a cancer survivor? That's the first question I think that I'd like to address with all of you. And the current definition is a cancer survivor is anybody who's heard the words, "you have cancer," for the balance of their lives. Now, earlier definitions also included family caregivers, but I think that for the purpose of studying this, we're just talking about the individuals. So it's by definition an incredibly vast group. The diagnoses, the prognoses, the cancer trajectories, the treatments are very varied. So sometimes we put some boundaries across the definition just for the purpose of studying or designing a program to meet the needs of that particular definition. Some people hate the term survivors, some people want to be called thrivers, some people think they don't deserve that term, some people wear it as a badge of honor. There are all sorts of experiences, but again, it's a term that has stuck, that is going to stay with us, and so instead of fighting it, let's just go from there. What do we mean by a good survivorship, or what do we even mean by survivorship? I think survivorship encompasses the entire cancer trajectory. We would call it care continuum if we were writing a grant. We'd call it a journey if we were talking to people who are living with this experience. But it's basically just thinking about all of the different phases and stages of the disease. And it's great that we're paying attention to this, because in the very early days of cancer treatment, the prize was curing the cancer. And then it was a pat in the back, you're done, everybody should be grateful, you're done, but it's not, you're not done. And what we've learned, and we've learned this really well from the adult survivors of childhood cancer, is their future health does not look normal. It is different, it needs to be studied. We need to understand the long-term and late effects of the exposures to cancer therapy. We need to understand what it was about that individual that led them to have cancer in the first place. We have a lot of work to do to deal with the psychological baggage they may be carrying as a result of this, the financial burdens that they may have acquired. So there's a science to survivorship, and that, I'm very happy to say, is growing. The more we learn about it, the more we can bring some of these lessons forward. So what survivorship has contributed, for instance, to the treatment of cancer, and I'm a medical oncologist, I treat people, mostly women with breast cancer, is that we've learned that there may be a price to pay for that cure. We have learned to try to simplify or de-escalate therapies to avoid exposures if people don't need to have more treatment. Mr. Irwin, you're probably happy you haven't received chemotherapy. Your current health and your future health may have looked different. So we embrace progress in cancer treatment, but some of the arguments in favor of thinking about the long-term consequences of cancer therapy have now been brought forward. We talk to young people about their future fertility before we treat them for cancer. If there are two options for treating cancer, we think and we need to have this conversation up front and include somebody and ask them what matters to you. And the prize is not just walking out of the cancer center, but thinking about future health. So I'm going to tell you a little bit about what's happened to the science and the history of cancer survivorship, and I have some comments in the next slides. And I would want all of you to think about what a successful survivorship is for you, theoretically, you as a navigator, you as a healthcare professional, as an advocate, or as a patient or caregiver. What does it mean? I think, again, thank you for cueing me, because you talked about it. You anticipated what life would be like with the treatment that was being offered to you. And you took the time to think about whether or not that was something that you wanted. And I think that's really important. And I think that's important for many people who are faced with cancer and who are surviving cancer. There's a growing number in, there are millions, maybe 18 million if you count, the numbers per our statistics right now, and that number is expected to grow. As the population ages, we're going to have more cancers and more cancer survivors. As the treatments improve, we're going to have more survivors. As we screen more people, find more cancers early, and treat them well, the ranks are going to fill. So it's a good time to be thinking about this. And finally, one of the very important issues for all of us is what resources do we have for them? Because again, many of our efforts in the cancer space have been to treat people and get them through kindly, compassionately, to improve their quality of life. But then we need to focus on the new people who need an appointment, who are filling our beds. And so we haven't necessarily in the cancer space paid as much attention to this as we should. So where did all of this start? Well, in 1974, a young physician, pediatrician, who was also an advocate, himself became a cancer patient, started writing about it. He talked about how difficult it was to get out of it. He then wrote this beautiful essay that was published in the New England Journal of Medicine, which is sort of one of our highest impact medical journals, talking about seasons of survival, saying it doesn't just end, but there are different chapters that we go through. And right around the mid-'80s, Dr. Fitzhugh Mullen and many others, advocates, scientists, physicians, started the National Coalition of Cancer Survivors, defined a cancer survivor in the way that I just introduced today, and started to move the dialogue away from these are victims, these are sufferers, to these are empowered survivors. And that's when the shift started. And you see the journey, right? The difference in terms, the difference in approach brings us more to a person who's activated as a patient, who wants to participate in making decisions, who is able to understand that treatments may have consequences, and able to draw in their own supporters and their network and their advisors and make smart decisions. And that is sort of where we are now. The government recognized that this was a distinct area. And so about 10 years after the advocates basically defined the problem, the government created the Office of Cancer Survivorship, led today by Dr. Emily Tonoresos, who is amazing. She's actually comes from family medicine, not from oncology, and is directing a very important and vast research portfolio. 10 years after the Office of Cancer Survivorship was established with specific funding for projects that wanted to study survivorship, so that's why this is all important, right? There was a report, and that report was the first time that this was not produced by any one university or by industry. This was sort of a group of stakeholders. It was put forward by what was then called the Institute of Medicine. And they basically brought together many people and said, well, what do we need for good survivorship? And we've been following some of the recommendations from that old report ever since. But basically, part of it was we need to create awareness about cancer. We need to have the whole healthcare system think about cancer survivors. We need to empower the cancer survivor themselves by at least giving them a treatment summary and a care plan so they know. And the idea then was, romantically maybe, because it didn't work out as well as they intended, but it was a good thought, was that if the cancer patient could, at the end of their treatment, be provided with a very clear plan, here's the treatment you got, here is the radiation field, these are the drugs, these are the long-term effects of these drugs. These are the late effects. This is what could happen to you 5 or 10 years from now as a result of being exposed to these drugs. These are the tests that we need to do in order to surveil you and keep you healthy, and this is the schedule of appointments you need. The idea was that armed with that plan, that was also going to be sent to the primary care physician of the patient and their community doctors could navigate survivorship. Well, it's not that simple, it didn't work out that well, but it was a good idea. So those of you who work in survivorship will know that it was very laborious to create these treatment plans, that they often didn't reach the primary care doctor, and they were configured in such a way that it made a lot of sense to the cancer clinicians, but many of the primary care doctors that I've spoken to over the years have said, this is not particularly helpful to us. So it's worked very well in pediatrics, but not universally as well in the field of adult cancer survivorship. So what are the elements of survivorship care? I've thought a lot about this, and some of this I've borrowed from a beautiful article that was published by Lidia Schapira, no relation to me, some years ago in the New England Journal of Medicine. So I will take the time to just talk about these because I've been able to convince the people at my own institution, and believe me, it's been a bit of an uphill climb, that these are the elements that need to be recorded as having been thought about if we're going to call a medical visit a survivorship visit. And I'm totally agnostic as to who conducts a visit. It doesn't have to be necessarily one discipline or another, but it has to be people who understand what we mean by survivorship. So what do we need to do? We need to surveil for cancer, and that's the same as we do for any regular follow-up appointment in the cancer space, as you probably have learned very well what that is. For lung cancer, it may be total body scans. For other cancers, it may be a blood test. For yet other cancers, it may be an endoscopic exam. So the kinds of things that need to be followed are going to depend on the type of cancer one had, and the period of follow-up will depend on how long we think that particular individual is at risk of having a recurrence of that cancer. With the women I treat who have hormonally sensitive breast cancer, that could be 25 years. So we need to have a transition plan as well for them. We need a risk assessment for future cancer. For smokers, smoking cessation has to be part of the survivorship care, right? For people who may have obesity, weight management needs to be part of the cancer survivorship plan. For people who are incredibly stressed, stress management may need to be part of this. So it has to be, again, forward thinking. This is sort of right there where survivorship meets primary or preventative care, although we're looking at it, again, through the lens of what could happen to this person because of their prior history of cancer and their treatment. Genetic risk update is very important for some cancers. It's very important for breast cancer because we're constantly finding new genes that increase susceptibility, and this information is important for the person and for the family. So for some cancers, this is part of survivorship care as well. Screening for second cancers, in some cases, especially in the case of lung cancer or head and neck cancer, we know that there's a vulnerability, and also as a result of having received radiation, they may be vulnerable to, they may have an increased risk of developing cancer in a radiated field or developing other complications. Now, the assessment of long-term effects of cancer therapies is also a very important part of survivorship. There are many cancer survivors who've been treated with chemotherapy agents, for instance, that cause neuropathy. Neuropathy often does not abate immediately with the last drop of chemotherapy. The recovery may take up to 18 months or 2 years, and some people are left with permanent neuropathy. We need to handle that. We need to figure out what we can do, and we need to do the science, and we need to do the work to try to figure out some mitigating strategies, because that can be functionally very important for people as well. Of course, people who are exposed to certain kinds of drugs or receive a large dose of radiation to their heart may be at risk for future heart disease, and again, mitigating interventions or prevention is important, and I've been very excited to see that, adjacent to survivorship has been the growth of the science of cardio-oncology. Cardio-oncology now exists, and there's a field within cardio-oncology called preventative cardio-oncology. So people who've been treated for cancer who also are at high risk for cardiovascular disease can be referred for a consultation for a customized plan of what they can do to reduce their future risk of heart disease. I mean, this is progress, folks. It's not just the immunotherapy, but it's all of the science that accompanies this to help people really deal with their future health. And talking about immunotherapy, Mr. Irwin, you look amazing and you sound great, but there are some people who get the benefits but also get some side effects of immunotherapy, and those people need our attention as well. And there's a growing science of people who are dedicated to dealing with the complications of immunotherapy in cancer survivorship. So we need them. We need those rheumatologists. We need the endocrinologists. We need the people who are going to be helping our survivors to live well. So we are not afraid to use the treatments that we have that can really affect the outcome so dramatically. and also advocate for and fight for integrating that into their general longitudinal care and survivorship care. People aren't just a series of organs. It would be great if we could have just deposited the disease organs in some place and pick them up when they're healed. But we carry them with us, and they affect us, and they affect who we are. And cancer is often a disease that creates a lot of psychological issues. People experience trauma, people are stressed, people are left often with fears, and again, that affects not just the patient, but the family caregivers who are in this as well. So we need to find good strategies for dealing with that, and I think you're going to hear more about that later. But I would say that supporting patients and trying to really try to think very carefully about how we can, from the beginning of the cancer journey, help people to feel comfortable telling us what they're worried about, creating safe places for people to be able to say that they're having problems, that they're anxious, or they have no interest in having a sex life anymore, or whatever it is that has accompanied cancer, for this all to sort of come out and be referred. Even if we who are listening to that, and I'm looking at my colleague here who's a nurse practitioner, often feel uncomfortable because we can't have a quick fix. We need to listen, and we need to do the proper referrals, because there are interventions and there are ways of mitigating those symptoms as well. And one of the issues that is very dear to the concerns of the cancer survivors that I have personally heard or studied, and my colleagues would say this as well, is that people often feel lost in the transition after active cancer treatment. They don't really know who to call. They have a cough, they call their cancer doctor. The cancer doctor says, call your primary care. Primary care says, oh, no, call the oncologist. And then they say, what do I do? Where's a friend? So I think these are the kinds of things, the elements of care coordination that are crucial to navigation. So if we think about how we can, if I've presented all the list of problems here and you think of the role of navigators, it will be obvious to you that there are many points where having good navigation, where having coordination, or feeling that you have the proper information to make decisions about your future care are really, really important. There are different models of caring for cancer survivors, and I know I have listed here quite a few things that I've addressed, but I want to tell you about these because in the classroom of cancer survivorship, this is what gets the most attention. I don't think this is necessarily the most exciting. I think people should know that there is no one model that's better than any other, that it's based on expertise locally. I mean, there are some models, for instance, that the models that are less complicated, say, of treatment of young adults who are cancer survivors, or children, adolescents, and usually it's because they don't have any other problems. They had cancer and cancer therapy-related problems. But as we get older, people have hypertension and diabetes, and they have a whole bunch of other things as well, which is going to influence their future care, which is part of the reasons why these survivor care plans are fine, but you really need expertise in survivorship care. So as I said before, there's an emphasis on providing some sort of a care plan to guide this care, but the care itself could be done in a shared model between people in the cancer space, nurse practitioner, physician, and people in the community doing primary care. It may involve other specialists. It may be nurse-led care. It may be navigator-led care. What we need is to put all of these different pieces together, and how they're put together may depend on where the expertise is, where the interest is, where the resources are, and what the needs of that particular individual and family really are. I wanted to also say that the reason that I'm presenting this in such an open, vague way is because almost everything that we've thought that was true about survivorship hasn't been demonstrated yet. So there is no evidence-based single survivorship model of care. In fact, Dr. Paul Jacobson, who's an implementation scientist with interest in mental health, in 2018 undertook a study with many colleagues who were doing great work in survivorship and analyzed the randomized controlled trials that have been done to see if actually people who received the survivor care plan had better outcomes in survivorship. Now, that in and of itself is a challenge, because when you're designing the study, people couldn't really agree on what the metrics were going to be used to say that survivorship was successful. So I put that out there because the people who didn't like the results of his study said that it was flawed, but for whatever reason, looking at this very critically and very rigorously, Dr. Jacobson and his colleagues concluded that there was really no evidence to support the notion that every survivor was going to do better if they had a plan. So the interest and the funding, and this is important to all of you, for creating these survivor care plans began to drop after the year 2018. So the funding and the accreditation bodies that had sort of demanded or said, you need to have a certain number of patients get a survivor care plan, started to change their language after 2018. And you will see that, that the language evolved. And I think it evolved well to basically say every institution that provides cancer care needs a survivorship program. So change from every person who gets cancer treatment needs a care plan to every institution that provides survivorship care needs a program. And I think that's smart. You can say that providing your patients with some sort of a care plan is part of what the program does, but it recognized that there are many other parts of survivorship, which is everything that I've been trying to name and put in front of you. All of these other elements matter. Providing patients with resources so they can better manage their care, providing navigation services so people don't feel that they're lost if they cough and they don't know what to do. So providing mental health resources, because we now have evidence-based mental health interventions that can help survivors deal with that anxiety, the fear of recurrence, in addition to other stressors that they may have experienced. So clinical studies show one thing for sure, that patients benefit when there's coordination. And coordination not just among the specialists, but also with their primary care clinician, whether that's a nurse practitioner or a physician. So we need to think of coordination. I would elevate that as a goal. There are barriers to receiving survivorship care, and they can include issues of communication. People may not have understood their prognosis. You'd be surprised at how many women I see in breast cancer survivorship clinic who basically say, can we go back to that initial conversation? Now, I didn't see them when they were initially diagnosed, but when I ask, what is your understanding of your future risk, it's often an exaggerated perception of future risk for that particular population. So I think that just going back to the elements, sometimes giving people a safe place to have these conversations is important when they're no longer in that, moment of having to make a decision and feeling their life is on the line. So, and new questions may emerge. So people need knowledge. Knowledge is power. People need coordination. People need communication. Our words can be incredibly helpful and therapeutic, or they can be problematic. And people often are left with phrases of, I hear, patients who tell me, but the doctor said, and they may have, that may have blown up, over the years as they were sort of thinking about that. So I think directing people, having care coordination, having teams, and if you have the luxury of having navigator roles, thinking about how to deploy them or having teams of navigators. We need community health workers to help us with navigation for certain population. We need peer-to-peer, we need buddy programs. We need ways of helping people connect. What we've heard in our studies of survivors is that people also want community. And that's something that we necessarily as healthcare professionals can't provide, but we can help create those spaces. So what are some of the functional problems that cancer survivors live with? Well, they live with, as I said before, some of the psychological repercussions. Fear of cancer recurrence rises to the top. It's difficult to ascertain exactly how many, percentage-wise, the studies vary. But this is something that is very important for the people living with this, and it may vary from disease to disease. Certainly, we've spent a lot of time in my program studying this, and we're designing interventions for this, but there are ways to treat these fears as well. And I would say that helping your patients, just think about the mindset that they bring to this. Think about how they're looking at this. Help them find a useful mindset. There's not a good one and a bad one, but there are useful mindsets. There are more useful ways of thinking about it. And again, my simple advice would be to help them view their illness, their health, their future health as manageable. Help them feel capable. Help them to know what they need to know. Help them get connected. Help them coordinate their care. That's really important. Monitoring for distress is important, even during survivorship, not just during treatment. The National Cancer Institute has just issued some standards of care for survivorship, which I encourage you all to read. There are 30 items there, but if you just pick a few, one of them you'll see is assessing for financial hardship along the survivorship trajectory. How has this impacted the family, and then making appropriate referrals. But people often live with fatigue way past the end of their treatment. They have trouble sleeping. Many live in pain. I've been in denial about that. Years ago, I had some very smart young postdoctoral fellows challenge me because the statistics said that 2/3 of cancer survivors live in pain. And I said, that's just wrong. It can't be. My patients aren't in pain. And they kind of looked at me like, oh, well, she needs time accepting this. And I have changed my tune. I have changed the way I listen to it, but it's difficult. And I'll tell you, as a medical oncologist, I will never forget, there are certain situations which have been personally very difficult for me. I remember several patients of mine who developed really bad neuropathy from their cancer treatment, and it was difficult for me to treat that pain. Because I somehow felt I had been an accomplice in treating the pain, and there came a point where I was not a specialist in handling it, and so I asked for help, people who really managed, neuropathic pain. And I think those are the kinds of journeys that, many of us go on, to recognize that, yes, we may be all gung-ho and let's treat and let's do, but sometimes there are some things that need to be dealt with. One of them that remains very thorny for patients is cognitive dysfunction. Again, this is something that any of you who are living in the cancer space know very well. There are many patients who describe brain fog or chemo fog or whatever. It's now thought scientifically to be similar to the problems in the brain that occur with aging. And some of the treatments really have to do with, concentration and attention and so on. Some of these things are recoverable and some are not. And so again, what it requires is an accommodation, just like you accommodate to a loss of a limb or a loss of an organ. But it requires, again, first of all, paying attention, diagnosing, referring, and then understanding also that we need more science to help us find better ways of dealing with these things. Something very different to cognitive dysfunction that's easy to diagnose and actually is fixable is bone loss. There are many people who have osteoporosis as a result of their as a result of their cancer therapies, and this is treatable but needs to be looked at longitudinally. Premature aging, all the organs age as a result of cancer therapies. You probably know that, but it bears repeating, and that's very important also for the young adults who were treated as kids, who maybe at 25 have the same risk of cardiovascular disease as somebody 2 decades older, and that needs to be known for them to get the proper care. Many of our drugs are gonadotoxic, so they will result in either infertility or reduced fertility. This needs to be addressed. And there may be many physical symptoms for lung cancer patients. Typically, it has to do more with pulmonary reserve, but there may be other issues as well, affecting everything from your desire to socialize, to your libido, to your ability to form relationships. Some people have wonderful survivorships and talk about being very grateful and talk about the silver lining, but they may not need our help very much. So what we need to do is focus on those who may not necessarily be voicing a lot of their concerns, but for whom there is really some help as well. So there are many lung cancer survivors, and I'm not a lung cancer expert, but with 2.5 million new cases, 1.8 million deaths worldwide, lung cancer is still the leading cause of cancer morbidity and mortality. And tobacco remains a culprit, worldwide. So I think all of us need to be very mindful of that. And that the 5-year survival for lung cancer is still low and changing with screening and changing with improved treatments. And that is the way that many other cancers have gone, and lung cancer is now on that conveyor belt towards better statistics and more survivors. The number of people living with advanced lung cancer in the US is estimated to be about 175,000. You probably know that better than I do. That was for me. So what do we think about when we think about survivorship and this particular population? And I would say that survivorship care needs to be both accessible and available. And, it just needs to be implemented based on needs of the population as they tell you, and from what we know from the literature. The people like you, Mr. Irwin, are now called meta-survivors. So there's a new classification as we in the field of survivorship have come to include and embrace people living with metastatic cancer, but living with this for long term. So welcome. And we are learning from one another, all of the communities. I think there are some elements of palliative medicine that you'll find in survivorship. If people are living with, they may be living with cancer on chronic therapies, like you'll be on this treatment forever, or they may be living with cancer and get treated intermittently. Like they may go, there may be times people with lymphoma certainly know this very well and have known this for a long time, that you may not need to be treated for months or years, and then, you need a little bit of treatment here and there. It's an adjustment. So this too is cancer survivorship. So the elements then for this particular population would be to have good primary care, so that so that you know what you need to do. I mean, do you need to have a colonoscopy if you're living with metastatic lung cancer? That's a question, right, for screening. So these are the new questions that come up now, and I think we need to build interest in the field, and we need to have a community also of trained primary care clinicians to help us co-manage and help us provide some of these answers. In preparing to come to address you today, I interviewed a colleague of mine at Stanford who is a professor of medicine, who is a beloved clinician, who sort of sits right where all of these services are provided to other patient, non-smoker, and was found to have stage 4 EGFR mutated lung cancer a few months ago. And Bryant has been very public about his experience. He's really trying to help, demystify any of the maybe old stigma that still surrounds living with lung cancer. And when I interviewed him and I said, I'm going to be speaking to lung cancer navigators, what have you learned from where you sit? And he said that he thinks navigation is probably the most important thing, that he was able to get his appointments, to get the information because of who he sits and where he sits, where his colleagues wanted to help him, and they helped him by getting him the appointments and by getting him to the experts. But he said, there's so many things that need to be coordinated. And I think, Mr. Irwin, you touched a little bit on that, on all the tests that all of a sudden appeared, and the letter that didn't come, and the phone call that came, and then, you also had to navigate getting cancer during COVID, which is a whole different situation. But I think that what Brian has said to me, and I wanted to transmit to you, is that there's really a tremendous impact on the experience of somebody who is now new to this world of cancer, who is facing disease that is really life-threatening, life-altering. And there's so much that needs to be done, the appointments, the information, that if all of that can be smooth, can be done with expertise, with efficiency, with compassion, thinking about what it is that where you're going, that can make a huge difference. Can make a huge difference to how people feel. Brian has decided to continue to see patients remotely when he can, when he's feeling well, but his colleagues want to protect him from being exposed to people who could be sick and make him sick. So I think there's tension there. But I think coming, sort of being open with the story can help others. And that's the part of creating community and having peers and learning from one another to normalize what is really a very, very abnormal situation. So what are the common challenges? I would say the need for continued management of the toxicities of treatment or potential long-term toxicities of treatment. Long-term is defined in survivorship as the problems related to cancer therapy that don't end when the cancer therapy stops. So they start with when you're getting treated, but they persist. Whereas late effects, you're getting an educational talk now. Late effects are with the things that happen years later. So typically late effects are the complications of radiation, which may lead somebody, for instance, to get a stenosis of their swallowing tube many, many years after they receive the radiation. Patients need help processing the trauma. Patients need help with the financial hardship that may be caused by cancer treatment, the social isolation and the stigma that persists. And in the U.S., we've been very open with cancer, but let's remember that there are many people for whom still cancer is something associated with stigma, something they don't want to talk about, and that's not something that you would know if you don't ask. We've done some very interesting studies with people who still have some cultural issues with being able to talk about it. Young women with breast cancer who don't want their mothers to know because they want to protect their mothers. Young people who are parenting little children and say, why would my children need to know? Well, because someday they're going to be adults and you need to talk about what you went through. So there's still a lot of that, and certainly in some of the series that we've done interviewing young adult survivors of childhood cancer, many of them talk about how the family just didn't want to talk about it afterwards because they felt they were reopening old wounds. But as a result, the young survivor didn't quite know their history, didn't quite know what to do. So be careful about that. People living in rural areas, people who may have preference for language other than English, those are the people that we need to reach out to. Those are the people that we absolutely need to know that are okay, and many of them are not. There may be some deserts of information in the areas where people live. They may not know anybody. They may not have a community to connect to. So I think that's where many of us, especially those of you who are navigating people, you can't take for granted what resources there are. You need to find out what there is in their community or connect people so that people don't get left behind. I want to tell you about some fun things in the last few minutes that we're doing. With me on this photo to my right is Stephanie Smith, who's a pediatric oncologist, and to my left is Elle Billman, who's now a medical student at Mount Sinai in New York, and Natasha Steele, who's an assistant professor of medicine at Stanford. And Elle and Natasha are cancer survivors. Elle was treated for leukemia when she was 2, and as an adult started to learn what that meant for her. And Natasha was treated for lymphoma she was diagnosed within a month of starting her residency in medicine and about 2 months after having delivered her first baby. So they're doing very well, and they've helped Steph and I come together. The 4 of us really designed a series to help we thought we were going to educate cancer survivors and caregivers. Haha, we got the education, and they taught us a ton, and they also taught us that they didn't want a course. They thought a podcast would be more engaging. So listen to our podcast. We have 12 episodes where we've really interviewed cancer survivors, mothers of cancer survivors, doctors who specialize in taking care of cancer survivors, mental health professionals, but it's co-led, and the whole project started with this idea that cancer survivors need more places they can go to, not just to get good information, but also to feel that they're part of a community and connect. So this is Lidia talking to Elle, who's amazing. Elle said that, she, in her family, she was treated from the ages of 2 to 5 for acute lymphoblastic leukemia. And then, she was fine and was getting her survivorship care and everything, but she didn't quite realize that she was different and a different trajectory until she was an adolescent in high school, and they had in class they had an experiment, or whatever their teacher was trying to help them understand the vibration and how we hear sounds and whatever. And so the class, all the students had to stand up, and they had to sit down when they stopped hearing at different frequencies. And she realized that, she wasn't hearing the way other people were hearing. And that was the first time that something clicked in her head and said, wait, I'm not hearing the way others hear. Maybe that has something to do with my cancer. And then she said, well, I'd like to learn how I was treated. And there wasn't a very easy way, so she finally found her way to asking for her medical records and got 500 pages. What was a 16-year-old to do with those 500 pages? But that just is one story that shows you, and now, she's thought about all the other things, all the other ways that her organs have changed as a result of having been treated for cancer. So that's part of the inspiration that we have, certainly, for, again, helping this particular cohort, but also thinking about what lessons we have learned that we can take forward with other groups. We're also very committed in our program at Stanford to helping advance education about cancer survivorship to clinicians. So we created, again, with a wonderful colleague, Jennifer Kim, who has a primary care clinic for cancer survivors. So she helped us figure out how we can pique the curiosity, really, of our colleagues working in primary care, so that if somebody with cancer is on their panel, they don't just say, oh, cancer belongs to the oncologist, but they can engage with this topic a little bit more. So we picked, again, 4 cases. We worked with educational consultants to make this fun. It's free, it's online. We give CME so that, basically, again, we make this as accessible and available as possible. So here are the references to our products, and also to general references. And with that, I want to thank you very much for the opportunity to talk about this with you today. I'm happy to take any questions.